Welcome, everyone, to this webinar of International League Against Epilepsy Mediterranean region. I would like to thank Gus and Jessica for putting this together, and I would like to thank our speaker, Dr. Tariq Jalul, for being here. And I would like to thank all the audience, and please keep joining for this interesting webinar. Please allow me as a moderator to introduce to you our respectful speaker. Dr. Jalul is a consultant, expert, neurosurgeon who graduated from the medical school at Tripoli University in Libya, 1989. He then underwent a formal neurosurgical training in the UK, completed by a prestigious fellowship in epilepsy and functional neurosurgery at King's College Hospital in London. He has enormous experience as a consultant neurosurgeon and epilepsy neurosurgeon. He worked at King Fahd Specialist Hospital in Dammam for many years, and he is behind establishing the epilepsy surgery program there, which is one of the big epilepsy surgery programs in the eastern region of Saudi Arabia. Since 2021, he is practicing as a consultant neurosurgeon in Libya at Tripoli University Hospital. Very thankful to you, Dr. Jalul, for being here with us tonight, and really appreciate the time you've taken to give us this lecture and presentation. The topic will be epilepsy surgery in limited resource settings. Such an important and essential topic for every neurosurgeon and for every epilepsy neurosurgeon, particularly. I'm looking forward to hear from you, Dr. Jalul, and please, for the audience, you can post your questions, and they will be answered accordingly. Thank you. The floor is yours, Dr. Jalul.
Thanks a lot, Dr. Najjar. That was a very generous introduction, and I really appreciate your efforts. And it's a real honor to be here speaking to you tonight. I would like to thank also Dr. Raida for asking me to do this talk, which I will start sharing, I suppose. So I'll just, it keeps coming to this slide. Okay, right. So yes, thanks to the ILAE, the Eastern Mediterranean region, and special thanks to Dr. Raida and to my colleagues and to Ali Mir in Dammam for helping me out with this presentation, especially in the last few bits of it. Basically, I will go through the title proposed through talking about a few points. Essentially, we'll start with the burden of the disease, especially the data in the literature pertaining to the surgical or the potential surgical patients. I will go through parts of the history or the main milestones of the history of surgery, because you wouldn't be surprised, or nobody will be surprised, I think, if we all know that neurosurgery is strongly linked to epilepsy as such. The first attempts of operating with the brain was mainly for epilepsy, in fact. The relevant part to our talk is the cost, the resources. Since we are talking about the low resources settings or countries, then we need to speak what's the evidence about the cost effectiveness of epilepsy surgery, about which many people, colleagues around the world have written and published extensively. Then we'll talk about the service needs and the actualities of setting up services and the challenges in the low settings, low resources settings. I will end up talking about our center in Dammam, the place I loved and I had the honor of working at with the other colleagues and the establishing the epilepsy surgery service there. I would reflect on that experience and try to draw some lessons and conclusions eventually, so we can all hopefully find useful in advancing our field. So essentially, the global burden, I think all of us are familiar with the burden of epilepsy in the world and the large numbers, which you find in the literature saying that it's about 1% of the population, of the global population, would have epilepsy at some time in their lives. The active epilepsy patients are estimated to be 51 million in the globe. Now you can extrapolate from this that roughly 10 million people are potential surgical candidates on the globe. And interestingly, 1.4 million is the number estimated of new surgically treatable patients annually. Now, the worrying bit is that the main burden of this disease and the surgical candidates of them by default lie on the low resource countries. So around 80% of the prevalence with its attached morbidity and mortality, they occur in the low resources countries. The highest prevalence seems to be in Africa and Latin America, and for some reason, interestingly, the incidence seems to be highest in the Middle East and Latin America. To make a few points about the situation currently, it's pretty clear that most of the patients, of the epilepsy patients and amongst them the surgical candidates, are in the low resource countries. Many of these countries, they do not offer option at all, or even if they offer it, their resources are limited. So in some of them, it's not even quite clear whether you can say that they offer this service consistently and persistently, or is it just an ad hoc sort of thing because of the limited resources they have. So the situation is not very good in the low resources countries. And even to make a situation worse, unfortunately, the gap seems to be widening because the population in these countries is increasing quite rapidly, more so than the high income countries. In my view, maybe we can debate that, but I think the expertise is more of an obstacle than even the financial details or the financial capabilities of these countries. I will go through a few publications pertaining to the situation. In this publication a few years ago, I think it was combined between a colleague from Nigeria and Queen Square in London. They reviewed 148 articles on epilepsy surgery and found that estimation, it's 31 countries from all over the world they published about epilepsy surgery, which means roughly 22% of the low middle income countries offer epilepsy surgery to their populations. And they found clear evidence that actually epilepsy surgery is less costly in these countries for understandable sort of financial and economic reasons probably, but it's not as costly as it is the case in high-income countries. In the ASEAN region, which includes the countries listed in the paragraph here, the epilepsy surgery is definitely underutilized due to lack of expertise. A country like Indonesia with about 270 or 280 million population, I think up until a few years ago at least, they only had 2 epilepsy surgery centers, and even the surgery they offered was only you can call it the straightforward surgery, or what we might define as level 3, not level 4. In Africa, the situation is not much better. In this publication by Kisani et al., there are the prevalence of epilepsy in Africa generally is about 11 per 1,000 population, which results in more than 3 million epileptic patients in the continent. 7 African countries only have epilepsy surgery out of the 51. And only 1 country offers the invasive monitoring stage, which is South Africa. Obviously, this was a few years ago again, maybe, because I'm pretty sure the situation keeps changing rapidly. And I'm not sure, but maybe our colleagues in the audience might correct me, but maybe Egypt has started performing the invasive monitoring. Now, going through a few milestones in the history of surgery, it's rather interesting to see that epilepsy was one of the first pathologies targeted by the surgeons, or the brain surgeons, if you like. If we talk about the pre-modern area, obviously they used only the trephination with various sorts of theories behind them. But if we jump rapidly to the beginnings of the modern medicine and surgery, then we find that Horsley and Jackson, they operated on a brain aiming to treat the surgery from the beginning. And interestingly, the National Hospital at Queen's Square used to be called National Hospital for the Paralyzed and Epileptic, because thinking that these are the main pathologies a neurosurgeon would treat. If we talk about Krauss and Chum, combination of neurologists and neurosurgeons, they, again, in the first half of the 20th century, they published a book, about 900 pages on epilepsy surgery. And Forster, who is a German neurologist and neurosurgeon, collaborated, I think, with Penfield at some point, and one of them visited the other. And they developed a cortical map jointly, I think. Penfield and Faulkner, also they had a special relationship. Now, Faulkner is a neurosurgeon from New Zealand who actually was trained and practiced afterwards in the UK, and did temporal lobectomies in the Moseley Hospital. We're talking about the 50s. So, epilepsy surgery is not a new invention. It's not a new finding. It's very old. It's as old as the modern neurosurgical practice. And it's worth noting also that hemispherectomy is not something new. It's very old, and the first who performed it was Dandy, but he was aiming at treating GBM, glioblastoma. But then that was picked up by Mackenzie in Canada, and he performed hemispherectomy for epilepsy in 1938. Now, fast forward, the first conference on a pre-surgical evaluation of epileptology was held in Zurich in 1986. The same year, there was same conference in the Palm Desert in California. The second one was in 1992. And I think from there on, it was pretty clear that there is a clear need and clear lack of epilepsy surgery to be offered to desperate patients who are pharmacoresistant. I think in a way, epilepsy surgery did pass through the same era like movement disorder surgery, because of the advent and the invention of new medications. Many people thought surgery is a bad evil, and thank God that we found medication, so let's stop it. Or it kind of sort of went quiet. And in the back, it wasn't at the forefront of treating patients, but both of them they witness kind of their advancements, and after it has been clearly evident that many patients do not respond to medications as was wished, and even the progress in bringing in the solve the problem. Some history lessons I thought of. I think we need to observe and be humble enough to know that the previous generations have done, a massive job, and they knew quite a lot. They achieved more than I think. Just through the details of their struggle, because we will find it helpful and useful. I think if you study most of the pioneers and the prominent figures who changed the field, you will find that dedication and perseverance was common. There were shared characters amongst all of them. The advances they made in their basic knowledge of basic neurosciences, in the anatomy, physiology, and pathology, and the clinical sciences and the semiological details, that made most of the difference. We shouldn't think it's only the technology, because in many instances the technology advances make our lives better. I think it may contribute massively to widening the number of people we can offer them the service. But in terms of advancing the scientific, the surgical field itself, it still relies on the pure core science. As I said earlier, introducing more medicines did not eliminate the need for surgery, and people recognized this a few decades ago now. Again, if you look at the relationships and the human relationships between different pioneers and different giants in the field and in the surgical field generally, you would find them humble and keen on collaborating with each other, because collaboration is absolutely pivotal and it is effective at all fronts. I think knowing all these details in the history would help us, build a better future, hopefully. I've got a bit of a... just adjusting my screen here. Okay. Now, when we talk about the surgical options generally, obviously we are witnessing advances almost every year or so. The surgery, the traditional surgery has always been resection or disconnection. But the stimulation part of, or the stimulation option started, in the last few decades, and the RNS added to the armamentarium of the stimulation options, which are VNS and DBS. VNS is the most widely or extensively used, but DBS also has a place and a role in treating some patients. The RNS is the last addition, and it's certainly promising to be one of the options we can offer our patients. The ablation options has witnessed a new invention, which is the laser interstitial thermal therapy, and also the focused ultrasound. So these two additions have came into action in the last few years or so, and they are certainly making the ablation options more exciting, and they may prove very instrumental in changing the field altogether. Radiofrequency ablation is an old option, but again, it's very effective, and in many ways, it's probably as effective as the latest ablation options in certain pathologies, at least. Radiosurgery has always been competing over the last 2 decades or so, and many advocates of that, including Professor Reiji in Marseille, who has had extensive experience with this, in addition to other experts in the world. But so we have many options in surgery, and we have just to tailor which option is best for which patient. Now, talking about the epilepsy surgery enthusiastically is not, does not cover the whole topic, fairly, if I may say, because to bring the patient to theatre is not just a one-stop shop. It's not like we found a tumor, the second day the patient needs surgery, and here we go, he's having the tumor getting out. Epilepsy patients, they go through a lot, and we need a lot of investigations from them, and it's a journey. I call it a journey. It's not just a one clinic and you decide and that's it. Decision sometimes takes long, and discussions and rediscussions happen quite frequently in the epilepsy teams. They are always teams, and they have to be I suppose in harmony, and they need to be led in a way so the team will be led in an effective and harmonious way that will reflect on the success or otherwise of the whole program. The details you need from these patients include electrical, video, radiological, on top of the clinical, semiological, and very detailed history. So it's an extensive or intensive, work of each patient before eventually reaching the theater. The investigations of an epileptic patient is, again, there's another peculiarity to epilepsy surgery, which is it includes surgery for investigating, which is the invasive monitoring because of various reasons we know. So quite frequently, our patients would go through surgery to be investigated and hopefully eventually to come to one form or another of surgical definitive treatment. The stimulation and modern ablation kits are particularly expensive, especially the LIT and the focused ultrasound, obviously, and the stimulation, including VNS, DBS, and RNS. They're all, advanced technologies, and they're fairly expensive, and they can't be offered to everybody. Maybe last but not least, we need to always to remember that epilepsy teams are large naturally and by default, usually, or ideally, I should say, but putting together clear policies and procedures helps organize the workflow, raise the quality, and avoid any problems and maintain safety of the patients. Now, when we talk about the low resources setting, again, sometimes we need to make tough decisions or, pragmatic decisions, I should say. For example, a few examples of them is, sometimes you might say we need to avoid the invasive monitoring because it's very expensive. We do only the non-invasive surgeries, or start at least, as usually happens, with the non-invasive stuff, and then eventually, if you can, you proceed with the level above of the epilepsy surgery. So at least the good side of the story is that there are multiple levels of the surgery itself, so you can offer your patients the first step and then work towards the next if you can over time. When we look at certain things, certain investigations, the CT and MR scan have become abundant, and they are reasonably available, although MR scan is still a bit difficult in certain settings, but generally speaking, we're talking about basic stuff. But whereas when we delve into the nuclear option, the PET and the SPECT, or even the MEG scans, these are expensive and difficult to implement and to utilize. And the choice should always be very practical and pragmatic and be cost effective. So choosing the more expensive stuff should be scrutinized in that sense. Even when we talk about surgical options, when we speak about resection or disconnection surgery, the traditional, the old form surgery, it's less expensive than implanting very expensive technology like the stimulators, or using the latest technology in ablation therapy. Now, a few slides about cost effectiveness of epilepsy surgery, which to me is quite pleasantly surprising when you look at the literature about this topic. And while I was preparing it, I keep finding every day a new evidence of it, because I think there seems to be a deep perception in the communities at large, or the administrators and the managers, that when we talk about epilepsy surgery, then we are as if we are talking about a luxury or something we can we shouldn't be thinking of. We should divert our resources to more core issues and more productive or cost-effective. So that seems to have, provoked the epileptologists and the surgeons all over the world to study this issue effectively, and they came up with multiple publications. Now, one of the noticeable analyses and reviews is the National Institute for Health and Care Excellence in the UK, which is a very respectable institute. It recommends what is effective, what's cost effective, what is what should be implemented and introduced in the NHS in the UK. So it's always worth, I think, looking at its publications, and one of them is this, which states in the conclusion that from the analysis, resective surgery appears to be cost-effective for adults with drug-refractory epilepsy, and I think they have the same conclusion in children too. It says the committee felt this was a robust analysis that would allow them to strongly recommend resective epilepsy surgery in both adults and children with drug-resistant epilepsy. Another publication from Germany only 3 years ago, I think, or so, which concluded with this statement. Basically, surgical treatment is cost-effective compared to medical treatment, especially when a lifetime horizon is adopted. It's concluded that all disease-specific costs should be considered over a long period when assessing the cost-effectiveness. It shouldn't be a short period. It should be looked at, within the longer period span. From an economic perspective, efforts should be made to improve access to surgical treatment for patients with drug-refractory epilepsy. Another old paper, actually, this is from San Diego in Chile. This was almost 25 years ago now, a quarter of a century. This group has concluded that even in Chile, the low resources country, the cost effectiveness of temporal lobe epilepsy makes them recommend it, and it should be something implemented in these countries. Another old paper justifying doing or choosing to do corpus callosotomy in Colombia, and they published the results with the estimated cost of corpus callosotomy. They obviously made the choice to avoid VNSs, which is some people like to call it the modern VNS. But if you can't offer your patients the VNS, you can offer them the corpus callosotomy. I mean, this is the message they are trying to convey. And this was quite a while ago, actually. Another paper, rather interesting this time, because it's from Thailand, but because they followed up their patients, and I have to say the number of patients is only 17 surgical patients. They followed them up only for 3 years, and they concluded that it did not show convincing cost effectiveness as per Thailand's economy or surgical cost. But they concluded, or they excluded, I would say, the temporal lobe epilepsy, which seemed to be cost effective even within the limitations of this study. Now, they do state clearly that to verify whether the cost effectiveness is justified or not, you have to follow these patients for longer. A fact we all know, I think, from other literature. Another publication, it's a multi-center publication here from the States, and it says in the 18 to 24 months following evaluation, epilepsy-related costs, we should say this is temporal lobe epilepsy, the cost was less in the surgical patients because of the dropping or the decline in their healthcare expenditure after being, treated for their chronic epilepsy. This is a paper which was agent-based simulation model aiming at assessing the Indian population and concluding that if two scenarios are applied, which is one of them is providing the first and the second line antiepileptics. The third scenario is providing the second line antiepileptics and surgery. It estimates, it's a postulation that in the first 10 years, of these scenarios, households avert an average over $80 million per year in medical expenditure. This is in India. Another publication in France, it's multi-center, 15 centers in France, and the follow-up was for 5 years. And they concluded with this statement that cost-effective surgery became cost-effective 9 to 10 years after surgery, and sometimes even earlier if the indirect costs were included in the assessment. Another American publication, which included, this is from Cleveland, which included a large number of patients, 7,800 patients, or roughly so, and 135 of them received surgery. The statistics to conclude with the statement there was a bit complicated, but they did, what seemed to be helping them in concluding with this statement. Basically, subjects that underwent epilepsy surgery had lower direct medical care costs and healthcare utilization. This was in 2016. So these are some of the publications providing evidence that epilepsy surgery is definitely cost-effective, and it is useful and beneficial to the society at large. And it helps bringing back people from, redundancy to work, and reducing the constant healthcare costs they always derive from the societies. Now, when we talk about resources, I thought, we might just determine what are they, and we can put them under the headings of 3 headings, I think. Human resources. The epilepsy team includes the epileptologists, which are, usually the leaders, neurophysiologists. Now, in Northern American tradition, I think neurophysiologists are by default part of the epileptology or neurology generally. In the European or Western European tradition, neurophysiology is a separate or independent specialty. The neurotechnologists, I put them here because I do find them quite extremely important, and they are they are the people who run the EEG and the EMU, and they help quite a lot. They help tremendously in montaging and preparing, and in helping the epileptologists and the epilepsy surgeons, and their role is absolutely crucial in my view. Obviously, the surgeons are integral parts of the team to provide for to operate on these people. Plus, some people would obviously ideally include the psychologists, psychiatrists, specialized nurses, and the technology from the various companies sometimes. So the team could be large or relatively smaller, with agreement of collaboration as per needed, like some centers do with the psychiatrists or psychologists. Some insist on them being integral or essential members of the constant team of epilepsy. But obviously, epileptologists and surgeon, you might call them the nucleus of the team. The equipments, they are various, and they span a large, the multiple specialties needed. Basically, the electrical, the EEG, the EMU, the radiological needs. Some centers prefer nowadays. It's becoming more and more news to utilize the MR scan 3 Tesla instead of 1.5, but 1.5 is usually enough. Then the nuclear studies, and in some very few centers in the world, they use even the MEG. So when we talk about equipments in the investigation part, it's quite extensive, but we need to, every team thinking of setting up the service would have to think about the practical and the most cost effective to start with, and then expand the service gradually. You don't have to go to the expensive technology from the beginning. Consumables are quite significant, like the electrodes and various bits and pieces. So they can be quite costly. The surgical needs also can be special in many instances when we do intraoperative corticography, for example, or the depth or the stereotactic EEGs. But otherwise, for the resective and the disconnective options, the usual settings of surgery usually are enough. So that's sort of a positive side to the surgical option when especially offering the non-invasive stuff. This slide is just to remind everybody that there are different levels of epilepsy services, and in the States, the National Association of Epilepsy Centers has classified the levels of epilepsy services to 4 levels. And the level 1 is the primary care, level 2 is the general neurologist, who probably would deal with most of the epilepsy cases and manage to control them. But then the few the less number who do not get controlled by the standard medications, they get referred to specialized epilepsy centers. In these centers, maybe some surgery would be offered, but not to the top level 4, which includes the invasive options and all the surgical options available. But we have to remember, and I think it's worth always reminding ourselves, that all levels are important. It doesn't mean that level 1 is least important, or it doesn't help us. I think level 4 cannot work if there is no level 1. I think we need to remember that epilepsy care is a pathway. It's not only one institution. It's a complete pathway. It starts from the primary care and ends up in the most sophisticated institutes. And organizing this pathway is extremely important. And collaboration and communication between all levels is quite helpful in achieving the best results in epilepsy care. I might have mentioned this already to some extent, but some of the decisions a team might want to take is it sufficient to just limit yourselves to the CT scans? Now, it's very difficult to do that, but I think it's not implausible to do that. But I think you will be forced to limit the patients you will offer them surgery if you don't have an MR scan. If you want to distinguish between the video EEG and the interictal concordant data, I mean, in some places they couldn't establish a video EEG or epilepsy monitoring unit. I think it might be debatable, but I think in my view, it doesn't mean that you cannot offer any patient surgical option, provided that you have a good epileptologist who's happy with the scalp EEG, who's happy with the rest of the data, the semiology, and the concordance of these two elements. You can probably provide some of your patients, especially with the lesional ones, you can provide them surgical option. But obviously, again, you will be limited if you don't have the proper epilepsy monitoring unit with the video EEG. You could argue also that instead of implanting invasive subdural or depth electrodes, which need surgical implantation and expensive implications, you can probably just utilize the sphenoidal and foramen ovale electrodes. Something I've never done in myself, but I think some of the colleagues are quite experienced in them, and they might elect to choose them for their patients, given the less cost they have. As I mentioned earlier in that paper from Colombia, I think they chose to offer their patients callosotomy instead of VNS. Again, if you're not offering your patients anything, then it doesn't mean that you just wait until the VNS is provided. Corpus callosotomy can still be quite helpful, and many people find it extremely advantageous. In this interesting paper, German colleagues have put together their thoughts in this paper. A few years ago, it outlines the way epilepsy surgery program is initiated in the low resources settings, and it kind of imagined the bases or the ground blocks are including chats, workshops, team building, video conferences, public relations, tandem partnerships, case conferences, training units, visits, exchanging visits, and internships. These are sort of the working blocks. On top of them, you would plan at some point to start building the pillars of epilepsy surgery, with the 3 stages: pre-surgical evaluation and the surgery itself and the post-surgical follow-up. And then you can see in the depth there the slightly shadowy pillars talking about the more complex diagnostics and the more complex surgical options. So it's a kind of a nice diagram summing up the imagining the plan forward to establish the service in a low resources setting. I put this slide on partnerships because I think they are extremely important for any program to start with, and any program to sustain, and any program to continue achieving success. The partnerships or the collaboration should always include locals in the same institute and in the same city, in the same country, and in the surrounding countries, as well as international partners and the high level experts, the global centers who hold the forefront of this service. With these collaborations, various collaborations, I think you can cover certain gaps. You can have the proper backup and support. You can have the mentoring, and you can have the lacking training you want. So collaboration is the magic word, I think, in epilepsy program generally, in the epilepsy surgery in particular. And I think I would probably stress on the fact that collaboration should include the neighboring people, neighboring cities, neighboring countries, because quite frequently you find yourself looking for something lacking in your hospital, and then you discover that a few miles down the road there might be somebody who can but it's just a matter of communicating and collaborating so you can help each other, and it will be a mutual benefit. This can apply to neighboring countries with low resources. Also, one country with low resources with the next country next to it, again with low resources, but there might be something available in one country not available in the other, and vice versa. And then this way, collaboration will help both of them establish some form of service and advancing it forward. This obviously does not mean excluding the collaboration with the high-level experts and the international centers. Now, a few words about some of the developing epilepsy surgery centers and programs in the last few years from all over the world in low resource setting. And this example is from Indonesia, a huge country with a very large population approaching, I think, 300 million people. As far as I know, they've only got 2 centers for epilepsy surgery, and they don't even offer, I think, the whole spectrum of surgical options. But they did manage to establish this center, I think, with some collaboration with Japan. They sent some people to train there, and they got some visitors from there to Indonesia, and they managed to take off, if you like, and started the service successfully, and hopefully they will continue advancing and developing. They stress on the fact that choosing your patients carefully and being stringent, especially in the first stage, would convince the community and the local community and the administrators and decision makers to continue supporting you. Otherwise, that might be a blow if you have bad results from the beginning. Another interesting example is Vietnam, where this center, the epilepsy center in Vietnam, collaborated with University of Alabama at Birmingham in the States. They wrote in detail their experience, and I think I find it enlightening, and it's quite a useful story to imitate and replicate everywhere. Some of the Vietnamese people who needed some training, they traveled to the States, and they were offered short fellowships, 2 to 3 months to intense sort of training, and the visitors from the States came locally, and they supported the surgeons in the first few cases, and then the program is just continued in a successful manner. This document was produced by the Telemedicine for Individuals with Epilepsy put together by a task force from the ILAE, detailing the way telemedicine should be utilized and provided for epilepsy patients. I would probably extrapolate or try to expand the application of telemedicine to the epilepsy surgery service too. I think it's very useful in communicating with other centers, sharing with them the electrical details, the radiological details, the pathological details. All of this can be can be done through telemedicine, and the program would find it very useful. We practiced some of it, or we utilized some of this in Dammam ourselves, and it was very useful indeed. In fact, telemedicine, as I mentioned in the last sentence there, it can be used even for training purposes successfully in certain circumstances. And now I'll delve into our local experience in Dammam, where I worked for a number of years there with very enthusiastic and esteemed colleagues from the epileptology and technology and neurophysiology and everybody. Even though Saudi Arabia is not an example of a low-resource country, it's a high-income country, but I think many of the notions we have spoken about, they are shared by our experience in starting or establishing the program, and many of the challenges are common to high and low resources countries. The convincing effort and the campaigning is also needed even in a high-income country. You need to explain and re-explain and try to convince and clarify the data and the literature and inform various sorts of people, especially the administrators and the decision makers. They need to understand the scale of the problem and the effort needed to try and help these patients, and explain to them that eventually this will be extremely cost effective and rewarding resources wise for them. Our team in Dammam included Professor Raid al-Baradri, who was the main establisher and the leader of the program, the director of it. Initially, she was the head of the task force to establish the epilepsy monitoring unit, and then the director of the program. I think every team has to have a nucleus, and you can say that the nucleus is there with Dr. Raida, Dr. Ali Al-Mir, who is the pediatric epileptologist, and Dr. Ziad Al-Thani, who is the adult epileptologist, Professor Faisal Al-Utaybi, who is a pioneer and internationally renowned epilepsy surgeon from King Faisal Specialist Hospital, who was kind enough to be there when we needed him, and he paid multiple visits to us and operated on some patients. And collaborating with him was an example of the successful collaboration to help kickstart the program and advance it. The team harmony and the leadership is of paramount importance, and with a cohesive relationship. The team would overcome the challenges and would seize any opportunity and would advance the program forward. It was a clear vision from the beginning that we should start slow, but we need to be safe, because starting safely would help our patients, and it will help the program succeeding and establishing itself. So we started slowly but surely, as they say. The national and international collaboration was instrumental, with multiple institutes around the world, multiple visits backward and forward, and the telemedicine, as I mentioned earlier. So this was, one of the tools which helped us establish and sustain the program and reach with a relative success. The stages of developing our program started with establishing an epilepsy task force, the aim of which was to, provide all the plans and put all the action plans to build the epilepsy monitoring unit and build the team and attract members of staff and fulfill any gaps in the logistics and the equipments and everything. Eventually, establishing the epilepsy monitoring unit and the surgery multidisciplinary team, which started meeting on a regular basis and discuss patients. We, as I say, because we started in a safe way, we started operating on lesional cases. There were success, alhamdulillah, and from there on, we built on our experiences and we started doing temporal lobectomies and with few disconnection procedures. Eventually, hemispherotomy was done, mainly for children, obviously. And eventually, we reached the invasive monitoring stage, including grids and electrodes and the intraoperative corticography. In fact, intraoperative corticography was started quite early in the establishing story. This was the opening ceremony of the epilepsy monitoring unit with Dr. Raida there and Dr. Shibani, who was the CEO then, and Dr. Rima Al-Bunyan was the ex-director of the Neurosciences Center when the epilepsy monitoring unit was opened. You can see her in the background of some of the pictures too. A few examples of our cases. These are post-operative cases starting from the left towards the right. A few lesional cases in the left side, temporal lobectomy at the top, hemispherotomy there in the bottom middle one, and here it's corpus callosotomy. I don't know whether you can see my arrow. And then eventually, as I say, we reached the stage of invasive monitoring with the subdural electrodes to lateralize a temporal lobe epilepsy. This patient went ahead and had the surgery successfully, and he was seizure-free post-operative, alhamdulillah. We did manage to publish our results of the first 50-plus patients a few years ago, 2 years ago, I think. And we had comparable results to the international data. And we described the population we operated on in detail there. It was noted, obviously, that in the Eastern Mediterranean region, epilepsy surgery remains underutilized, and hopefully we can all together advance it forward. Further few publications regarding the SPECT. Cut a long story short, it's not, here we are supportive of the fact that SPECT utilization should be selective and should be stringent, because it doesn't always help. And in fact, we recommend that whoever wants to use SPECT should have the facility for invasive monitoring to make it useful utilization. So it's not an essential part of any epilepsy program. It could be helpful in some of the more complex cases, like the diffuse pathology or cortical dysplasia. Another publication pertaining to the intraoperative corticography, we used it, as I say. Actually, we started early in the program. Part of the reason was to establish or to build up experience and build up the team. So we used it a little bit more liberally. And this was a review of these patients, and we prove here that ECOG is quite predictive of a good result, and the silence of the EEG post-resection is usually quite promising of a very good result. Persistence of spikes or even the mild suppression of them usually would not yield an Engel class 1. It usually varies between 2 and 4. I think there was a systemic review also from the Netherlands a year ago about this topic, and they probably sort of reached the same conclusion with a more extensive review they did, obviously, because ours is only one center and the number of patients is not quite large. So points to take away. I thought of some of them, I hope you find them helpful, but I think some of the most effective procedures, as I said earlier, resective and disconnective, are more affordable. So don't be, overwhelmed, or don't be put down by the complexity of the epilepsy service or the complexity of the investigations or so. I mean, you can always start, as I say, slow and start with limited number and then build on your experience and expand your surgical options as the resources allow you. I think it is worth remembering that history tells us that technology is not the only part of advancement. In fact, it is more a human advancement, more understanding, more effort, more detailed knowledge of the semiology, the pathology, the physiology, these really make a larger change and improvement, I think. I think from the experience we have, even locally in the MAM, expertise is the main asset and the best investment. Finding the experts in every subspecialty, retaining staff and maintaining them is very challenging, even in our setting where resources where the income is high. But having the right people at the right time and maintaining them and sustaining them remains a challenge. And I think we need always to put in mind that a human asset is the most expensive. Collaboration, as I mentioned earlier, all of the collaborations are very vital and important. All types of collaboration, local, national, international, regional. Patient safety and program success dictates that the gradual initiation and constant re-evaluation and revisiting the performance and adjusting accordingly is extremely important. To establish a program and to embark on it, public relations, the patients and the communities at large are very supportive, and they are part of the team. Consider them as being parts of the team. They're not just being served. They are shareholders, they are partners, and they will make they will be part of your success. So I hope we understand the brain network. Networks take a lot of patience and effort to understand and fix. I think that's what makes epilepsy sometimes challenging, but it's a pleasant challenge, if you like. And I would finish with this quotation: an organization is only as good as the people who live and work in it. I think it tells a deep wisdom there, and I strongly believe in it. I think people, and people. Thank you very much.
Okay, thank you very much, Dr. Jalul, for this nice and wonderful presentation on this very important topic about the epilepsy surgery in limited resource settings. And really enjoyed it a lot, me personally. We have lots of audience who were there throughout the presentation. And very thankful to you, Professor, for being here with us. And I personally have a lot of questions, so we'll see the question and answer box. So please, I would encourage everyone to post the questions for Dr. Jalul to answer. Now Dr. Raida is greeting you, Professor Tariq. Thank you, Dr. Raida, for the nice comments and for the continuous support. So, Dr. Tariq, there is one question from Frederic Duenas. So thank you so much for your presentation. I would like to ask, how do you deal with the absence of neurosurgeons specialized in epilepsy? Does the outcome change? Please, what are your thoughts about this?
Yeah, thank you. Thanks for the important question, obviously. Yes. I think the ideal situation would always entail specialized training or subspecialized training in the field in an experience center. Now, I know and appreciate that this might not be available all the time, but I think if one would want to sort of reassure my colleagues all over the world and in our region too, that with experienced neurosurgeons who have the basic safe level of knowledge and skills, they can learn these procedures, or at least some of them, with the support of more experts or experienced people. And that's where the collaboration, plays a major role. Like the Vietnamese example, that was, as I say, enlightening, really, because the neurosurgeons there, they did not lack the basic surgical skills. They were operating on, learning the extra step of epilepsy surgery. It was doable with the help and with the support of the international colleagues. Can you hear me, Dr. Najjar? Sorry.
It was cut for a bit, but now we hear you clearly, Dr. Jalou.
Sorry. Okay, sorry. I think it's a net instability. I'm sorry. I hope during my talk it wasn't unstable. Did you hear me?
It was very good. It was excellent, Dr. Jalou. It was so clear. But now your voice is gone, Dr. Jalou.
Oh, really? Why is that?
Now we cannot hear you.
Oh, really?
If you can get just closer to the microphone, that I think it's a.
Okay, 1 second. Can you hear me now?
Now is better.
Can you hear me now? Can you hear me now?
Yes, Dr. Jalou. But if you can go louder, please. If you can come
Oh, really?
louder, please.
Okay. Yeah, well, I have nothing to say now, but I just want to make sure that you hear me. That's all. Sorry.
No, so I echo you, really, Dr. Jalou, and I think your insights about this are so excellent. So what is really important is that some of the epilepsy surgery procedures are really standard in neurosurgery, and of course, maybe it's a better outcome when epilepsy neurosurgeon is there with experience, but some procedures like temporal lobectomies can be done by a standard practicing neurosurgeon who knows how to do it. Because the outcome of lobectomy, especially temporal lobectomy, when it is done properly, is very encouraging and very good. Let's see the questions and answer. Hello from Mongolia. Hi, Abai. Soma, thank you, Professor, for the quality of the communication. Dr. Jalou, I have some insights or questions. In every country, there are some countries who are really limited in resources, so even the basic surgical equipment are not available. Then obviously in these countries, we cannot really practice any epilepsy surgery. But in a lot of countries, even the high economy, there are many centers with limited resources. So some would argue if you don't have an EMU unit in your hospital, you cannot do any epilepsy procedure. What is your comment about that?
Yeah, thank you, Dr. Najjar. It's all relative, isn't it? I think, I suppose safety of the patients is definitely first and foremost. But I think I did go through this very quickly that, some of the patients who have lesions, for example, some tumors, and they are epileptic, and if you have a reasonably trained neurologist who assures you that the scalp EEG is concordant with the lesion we see on an MR scan, then I think you can go ahead and resect it, aiming for treating the epilepsy. In that situation, you can probably take your patient without the long-term monitoring on the video EEG. But I think, generally speaking, if you want to establish an epilepsy surgery program. Video EEG is absolutely essential, with a few exceptions. You might say the exception I mentioned a minute ago.
Okay, and I'm sorry, you mentioned a lot about the callosotomy as an alternative to VNS. What are your comments about that? I know that callosotomy is much more invasive than VNS, so some would argue even if you do a total callosotomy, you might do more harm to the patient than if you are doing a VNS. What are your comments about that, Dr. Jalou?
Well, I mean, I think we both agree that VNS is a better option in most of the generalized and intractable epileptic patients, like the examples I just quoted in the Colombian example, in Colombian study. But at the same time, people have to be pragmatic. If there are a population, there are patients who are not offered anything, and the VNS is out of question, then you're offering them corpus callosotomy, which is the old traditional way of treating the intractable generalized epilepsy, is better than just leaving them to their fate, if you like. And obviously, with one exception is the drop attacks, as you and I know, they are still offered the corpus callosotomy even in the VNS era. But I think the example from Colombia just shows us that sometimes you need to make pragmatic decisions. If the expensive technology is not available, then you offer them the second best, which is the traditional surgery.
Okay, thank you, Dr. Jalul. There is one last question from Abai Siyaz. She thanks you, and then or he. And how about neuropsychological testing to locate epileptic foci? I think what it means in limited resource setting, if we don't have a neuropsychological support or a neuropsychologist, should we proceed with epilepsy surgery?
Good question, and I totally agree. I mean, proper and detailed neuropsychological assessment by an experienced specialist is very helpful. It tests the memory, the cognitive function, and the reserve of the patient, and even explores and sometimes reveals certain psychiatric background. But the lack of them, even sometimes in high-income situations, makes them quite precious. And I think, the other clinicians might do just basic batteries of testing. Some neurologists would just go through with very basic stuff. With those, I think you can go ahead and, offer your patients surgery. But the ideal situation remains with an experienced neuropsychologist in the team. It's not an absolute essentiality, but if it's not available, then the other clinicians would have to cover this gap, at least at a basic safe level.
Thank you very much, Dr. Jalul. I would really I agree with that, and it's always important to remember, if you allow me, that the most important question in limited resource setting, who are the patients that I could benefit the most? If I could answer this question correctly by selecting appropriate patient, doing appropriate investigations, and giving or offering the appropriate treatment, then probably the program will start with successful stories. I will, sorry for the extra minutes. So I think we don't have any other questions. All right. Dr. Jalul, any final thoughts? We really enjoyed this webinar, I think, as well as the audience. I really would like to thank everyone who put this together, especially Dr. Raida and Jessica, Gus, and everyone. And a special thanks to our special speaker, Dr. Jalul, for being here with us. Any last final comments, Dr. Jalul, before we close this webinar? And actually, it was a successful webinar.
Thank you. Thank you. Well, first of all, thank you very much for giving me the honor of speaking to you here, and I'm really grateful to everybody of you. And I was really more pleasant when I met you, Dr. Najjar, and I thank Dr. Raida for inviting me. I think the future of epilepsy surgery is only expansion, expansion, and expansion. And I think, we shouldn't always concentrate on, trying to do the latest technology or the latest inventions, apply them directly. We should think about the whole process in steps and gradually. And I re-stress on the fact that collaboration between the neighbors is extremely helpful and useful, as well as it is with the higher centers who usually are far away. So tonight's platform is very important, and I think it does help in that way of knowing each other, communicating and collaborating eventually for the benefit of our patients and our communities in the region.
Right. Thank you. Thank you, everyone. I wish you have a good weekend and good holidays. And hope to see you soon in another webinar. Uh, Thank you, and have a nice rest of the day.
Thanks a lot.